All right, everyone who's live, welcome. We're going to be going live once or twice a week now with the providers here at MedMatrix, talking about different topics, everything health and functional medicine related that we get from patients every single day. So today we're going to be talking about a couple of things. We're going to start talking about female hormone replacement therapy and menopause, and some of the bioidentical hormone replacement treatments that we have available at MedMatrix. And disclosure, anything we talk about today is not medical advice. But with that said, we are joined by the lovely Dr. Rose. Dr. Rose, thank you so much for joining.
Thanks
After
for
a
having
long
me.
day of work. Yeah. How many patients do you see today?
I saw 13.
Nice. That's a busy day. Normally it's like 7, right? Or 8.
Depends. Yeah, it definitely felt full.
Yeah. Was it a lot of more follow-ups?
More follow-ups, only a couple new.
That's awesome.
Yeah.
Cool. How did that go? Before we get right into stuff, when do you normally start seeing improvements in patients? How often are patients seeing improvements in 3 months versus, taking 6 months to a year to really notice different changes in their health, versus just really that different for everyone?
Are we talking specifically people who start on bioidentical HRT?
Or no, we're just broad.
Broader than that. It doesn't usually take. Usually within 3 months, we can start to see if we're going in the right direction. Yeah. I mean, the way that I usually talk to people is in general, this is a slower medicine because we're supporting the body's own healing, own metabolic pathways. We're not really suppressing anything, but I can usually tell by 3 months if we're going, if we're headed in the right direction, if we're on the right track.
Okay, cool. Well, we'll probably do another episode on the timeline and expectations of functional medicine, but we got to stay on track, and my squirrel brain will get us totally off track. So let's go back to hormone replacement therapy. So can you give a little context just on your expertise with hormone replacement therapy, specifically for females, and bioidentical hormone replacement therapy?
Yeah. I mean, it's probably, I would say 75 or 80% of what I do every day involves evaluating kind of a woman's baseline hormonal status. And that includes lab results, which I'm sure we'll talk about more, and her current symptoms, just her history, and discussing whether some form of bioidentical HRT makes sense for her. So it's, and I've done a fair amount of continuing education over the years. I try to stay current. As our viewers may know, I mean, things are changing, I think, for the better in the kind of in terms of mainstream awareness. So just kind of keeping up with that, and both in terms of safety, efficacy, what forms of hormone replacement make the most sense, meaning topical versus oral.
Gotcha. Okay, cool. So let's start with, got a bunch of questions here that are pretty common. So because people go to their primary care provider or conventional doctor, and very often they'll ask for, things like their sex hormones tested. We hear this all the time from patients. And either they're just told flat out no, or sometimes I'm sure they say yes, but also a lot of times they say blood hormone testing through blood doesn't actually matter. How much of that is true? How much of that is not true?
So we like to get baseline blood work on women for a couple of reasons. Every individual is different. So whether or not we're going to start kind of treating somebody with hormone replacement therapy, it's always just good to get kind of a baseline, and then we can decide, is there something really kind of abnormal that we need to investigate further? Are things appropriate given her age? What we see on blood work, does that match what she's telling us in terms of her menstrual cycle, when she's perimenopausal, menopausal? Can we match her clinical presentation to what we're seeing on blood work? And so I find it as a clinician extremely beneficial to just kind of have that data and then have a very kind of informed discussion with her of what are her options. Is it safe for her? If so, what makes sense? Rather than just relying on what she's told me. So I really value having the lab results.
Okay, gotcha. So like in 30 seconds or less, like when is blood hormone testing good for sex hormones and when is blood hormone testing bad and misleading for sex hormones?
I don't think it's ever bad for,
okay.
Yeah, I don't think it's ever bad. I think it's always valuable. I think there are some instances when it's not absolutely necessary, but it's never bad.
Okay, so when is it necessary to do something like a Dutch test that's like, I know saliva testing or, over a period of time? When do you need more in-depth sex hormone testing more than just blood?
So just to let people know, a Dutch test is usually urine and sometimes saliva. And what it does is it tests what are called sex hormone metabolites. So rather than just getting kind of a blood level or a serum level of a hormone, we actually see kind of the metabolites, which are breakdown products. And it is kind of the gold standard in terms of especially managing hormone replacement therapy. So ideally, somebody comes in, we have baseline blood work, and then say 6 weeks, at least 6 weeks into treatment is when we would do a Dutch panel. And that would kind of show us how well she's responding. And what it shows us is what's happening at the level of the tissue or where the receptors are, the estrogen receptors, the progesterone, the testosterone receptors. And so that's like just more specific, a little bit more accurate than the serum or blood levels. It's not always necessary. It's not always convenient, but it's great for certain people at certain times during that treatment.
Okay, gotcha. That was a great explanation. Thank you. So, all right, switching topics a little bit. Okay. With testosterone in female health, because I know like we get this all the time. Females asking, hey, do we offer, do we look into testosterone for female health? Yes, we do. Why is testosterone so important in females' health? Because you hear it all the time in like men's health, testosterone, very rarely around female health. And I know that's something that, sometimes gets brushed over. So yeah, why is testosterone so important in female health?
Yeah, it's, again, I'm kind of excited because I think there's now a conversation around this. And up until I think quite recently, it's kind of been it's been taboo. It's been a no-no in terms of giving women testosterone. And I think there's more research and more conversation around the benefits of women having adequate levels of testosterone. What does it do? Yes, libido. Yes, like sex drive, but overall drive, overall interest, and like motivation, in mental clarity. So women also talk a lot about brain fog in those perimenopausal and menopausal years. We see benefit, yes, from progesterone supplementation, but also testosterone as well with that kind of mental clarity. And then on the physical end of things, like muscular strength, muscle tone, just that lean muscle mass, that you definitely get a benefit from taking testosterone.
Gotcha. Pretty important.
Yeah. And I think that, it's when dosed appropriately, like at the right concentration, at the right dose, it is extremely safe. And I think that's kind of where the misconception has been.
So what about all the ladies out there who are like afraid they're going to like grow a mustache or like
I have never seen that happen with all the women that to whom we prescribe testosterone. Maybe if you took way too much, but I don't know, dosed appropriately, I'm not seeing it. And you have to look at it in the big picture. You have to make sure that estrogen levels are adequate too. The estrogen and testosterone are sort of competing. And so you don't want somebody to be so what we call androgenic, like the testosterone level is so high that like overpowers estrogen. And in a postmenopausal woman, her estrogen is low. So most of the time you're wanting to boost that estrogen as well so that you don't get that, you don't get unwanted body hair.
So if you're post-menopause, like 99.9% of the time, your testosterone is low.
Yeah. So there's, I mean, I don't know if you want to get into it, but there's the normal versus optimal, right? And so there's like the labs have the reference ranges of what's considered normal, and that a woman's testosterone levels could fall within normal, but our definition is different, right? Like we would see that we have like an optimal level that's safe yet higher than what some other conventional medical providers might consider to be normal. And I'm always bringing in her lived experience, her clinical presentation to match that. We're not just treating her serum levels of testosterone.
Sure. Yeah, fair enough. All right. So let's talk a little bit about the difference between bioidentical hormone replacement therapy and synthetic hormone replacement therapy.
So, yeah. Synthetic is similar to our own endogenous hormones. So like the chemical makeup of our own hormones. Synthetic is similar, whereas bioidentical is actually identical. Bioidentical hormones are usually sourced from wild yam, sometimes from soy. And because the chemical makeup is identical, the safety profile is better than synthetic. That's the short answer.
Okay, so why does, like, is there ever a time that like synthetic makes more sense than bioidentical, or is it just like why would conventional medicine even use synthetic hormones?
Maybe cheaper, maybe approved by insurance companies. Just kind
There's
of.
no like clinical answer though.
There's
like,
no clinical reason. No.
Have you ever used synthetic hormones, or are you always using bioidentical hormones with patients?
I have never used synthetic.
Okay, gotcha.
I have women coming. I have had women come who are prescribed by somebody else, and we have that conversation, and maybe we switch to bioidentical. But I don't think I've ever been the prescriber.
Okay, how often are patients coming in who are already on hormone replacement therapy, who are coming from like a conventional medicine doctor, on synthetic hormones versus
It's not that often. Not that often. Yeah, I think. Well, I mean, I have women coming who are on oral birth control, and that's synthetic. That's synthetic hormone replacement, or an IUD, a hormonal IUD, that is synthetic. So if I include that, then yes. But in terms of kind of what we think of as hormone replacement therapy, usually for women who are, 40 and over, these days, most people have not. They've maybe tried. They've asked primary care. They've asked gynecology, and for whatever reason, have been told no. So they're usually not on anything. I can't hear you.
Sorry, for those who are listening, I was accidentally muted. Okay, so for women who come to MedMatrix who like, have night sweats, like they're having all the menopause symptoms, they're tired, they're putting on weight, they're not sleeping, they're anxious, they have no sex drive. Like, we hear this all the time where doctors are putting them on birth control. Like, what do you think of that as like a solution? Like, is birth control a good solution for menopause symptoms?
I would say no. So one, it's synthetic, and I just finished saying how the safety profile of bioidentical is better than synthetic. Right. We cannot adjust. The other thing is that part of that is also the route of transmission. So in general, especially when we're talking about estrogen, specifically estrogen, you want to do transdermal or topical, not oral. So there, and that's just a safety thing in terms of reducing your risk of blood clots. So, so the other thing with oral birth control is that we cannot tweak the dose, right? Like once a woman's on that dose, we can't adjust it. And with bioidentical hormone replacement, we can get super specific in how much oral progesterone and how much topical or transdermal estrogen. There's several different types of estrogens, so I can adjust estriol versus estradiol, one stronger than the other, can get very specific in the dosing and really match that woman's individual needs. And we just can't do that with oral birth control. And so if a woman, really the reason to do oral birth control is if a woman needs it for contraceptive purposes. Otherwise, I don't see why. I don't know why one would. Right now, I can't think of a reason why I would pick that over bioidentical HRT.
Mm-hmm. Gotcha. All right. So, let's see, I got a list of questions here. At what age would you recommend a lady, or I guess either at what age or what things should someone be experiencing to, consider coming to a place like MedMatrix for help with their hormones?
I mean, it can, if a woman has polycystic ovarian syndrome or PCOS, she could be in her 20s or 30s, and we would, start working with her on the appropriate HRT. In terms of kind of the perimenopausal transition, like that can start as early as 35. We really see women experiencing some of these symptoms 10 to 15 years before their menses actually stop and they are considered menopausal. I would like to point one thing out, which is that we're not necessarily going to see dramatic changes in the blood work at that time. Like women are often usually symptomatic for that 10 to 15 years before we look at the blood work and we're like, oh yeah, you're menopausal. So what am I looking for blood work wise when a woman's perimenopausal? It's any real red flags, anything that looks super off. But mostly, again, it's just that baseline. And really what I'm prescribing on is she fatigued? Has she gained weight? Is she having trouble sleeping? Is she irritable? Has she lost her libido? And is she having hot flashes, night sweats? And again, based on that, deciding what combination of bioidentical HRT makes sense for her. So I think that answered your question. It could start depending on what the woman is coming in for, or maybe it's regulating cycles, that could be a woman in her 20s.
Okay. Gotcha. Thanks for sharing. All right. Why is menopause and weight gain linked? Like how, because we hear it all the time where, men, but specifically for this talk, women, they get older, weight becomes harder to lose. What role do hormones play in that?
It's usually that drop in estrogen. And so we see.
Oh, really? So the estrogen is the one that's linked to the weight loss. Or sorry, the weight gain.
Yeah. It's usually, and it's like really that kind of midsection, menobelly, as they call it, is often, it's often where that's the most common part of a woman's body where she's going to notice the weight gain. But overall, it's super. I can't tell you how many, I'm sure you've heard it when people call. I hear it every day. It's like, I haven't changed anything. I eat really well. I haven't changed how I eat. I work out however many days a week. I haven't changed anything. And yet I just can't lose the weight. And, I look at her age and it's kind of, I don't want to simplify it. Things like excessive stress, things like not sleeping, which may be hormonal, also are going to it's going to make it harder to lose weight. But it's usually the way that it's described is like, you kind of know it's got that hormonal flavor.
Okay, sure. So for like realistic patient expectations, how often do women come in with weight and you fix their estrogen and then all of a sudden things start working like they used to?
Yeah. So, and it might be estrogen, and again, putting in a little bit of testosterone can also help, depending on the woman. But I would say that overall body composition can definitely improve. We can start to see a little bit more of that kind of lean muscle, a little bit of fat metabolism, a little bit of less weight. If a woman comes in and she needs to lose 25 pounds or more, I'm not going to promise her that that's going to just come off in a couple months without adding anything else in. I mean, I think it's really about, again, the body composition, kind of like feeling better in your clothes, losing, I'm going to say, somewhere in that 5 to 15 pound range can maybe be realistic. She still has to do the work. She has to move her body regularly. She has to eat well. That's a whole conversation. Yeah, I think it's that kind of weight. It's not somebody that comes in and has to lose 100 pounds.
If your sex hormones are super screwed up, is it impossible to lose weight?
Without balancing your hormones?
Yeah.
If your sex hormones are super messed up, is it impossible to lose weight? Is that the question?
Well, I guess let me ask a better question to preface that. How because obviously there's varying degrees, right, of everything. So with menopause, could you give a distribution of what percent of women their hormones really messed up and they really, because I've used to talk to a lot of patients who would come in the door, and some of them it's menopause, it's all right. Some of them are this changed my whole life, this ruined my life. What's that distribution look like generally?
We're talking about women who are menopausal or postmenopausal. Yeah. Is that right?
Yeah.
Okay. I would say that the majority, I'm going to say 70% of women, let's see, it's such a gradient, right? I mean, there's women who became depressed, gained a lot of weight, can't sleep more than 3 hours at a time. Everything's just off, right? Really severe, intense hot flashes, night sweats, you name it. That's going to be the minority when it's that bad. And then there's the handful who are it just stopped and I didn't notice anything and nothing changed. And, and that's also a very small percentage, right? So the majority are there somewhere in the middle where it's I can't sleep anymore and I'm tired and I have brain fog. Those are the biggest. And then I would say a smaller percentage, they have all of that and they're dealing with night sweats and hot flashes. So I think that answers your question. I mean, it's such a range, and it's everyone's affected differently, and it's multifactorial. There's other hormones are a big piece of the puzzle, but there's other pieces in terms of lifestyle, diet, stress level, all of the above. Other coexisting conditions.
Gotcha. Yeah. So I know in the past you've talked about the link between your adrenals, your thyroid, and your sex hormones. Can you talk about how, because when you go through menopause, your sex hormones change, but that also affects your thyroid, affects your adrenals, which affects other things. Can you talk about the cascading effect of menopause?
Yeah, I think of it as a triangle. So I think of it as the thyroid gland, the adrenal glands, and the ovaries when we're talking about a woman. It does apply to men also with testes, but we're talking about women in this podcast. So it's a triangular relationship, which means it's not linear. So and these are all hormones, right? This is all within the endocrine system. I think or in conventional medicine, there's this idea that, somehow the thyroid is off on an island, the adrenal glands are off by themselves, and then you've got the ovaries and somehow they're separate. All of these hormones are in the blood together. And these glands in particular, these organs, have kind of a relatively complex relationship with each other, influence each other. So if there's been chronic stress, if there's been trauma in this person's life, either early childhood trauma, later in life trauma, years of chronic stress, you name it, super common. That is going to not only impact cortisol levels, but also thyroid and sex hormones. Likewise, if a woman has, kind of estrogen dominance or some kind of more sex hormone imbalance, that's probably going to show up in the thyroid. Like, it's just all together. And that's, I think, kind of where we specialize or where we shine, is like kind of having the tools and the skills and the testing to figure that out and kind of get to the root of it. It's not like it's not like the goal is to say, oh, it's actually your adrenals. Like, it's probably a little bit of both, but let's figure out where the imbalance is. What needs the support? Where do we start? And that's a little bit of that, like stepping back and looking at the whole person, and not just throwing, even if it's a natural supplement, not just throwing a natural supplement at somebody, but like really figuring out where this specific woman's overall hormonal imbalances and how do we support her.
Yeah, totally. I mean, that's I think that's what patients are looking for. It's a more holistic approach. So what are your thoughts on, like, I know there's services out there like where women can actually get hormone replacement, bioidentical hormones online, things like main one I've heard of is called Winona. What do you think of that, where women are just ordering like hormones online, getting it shipped? It's obviously some cookie cutter dose. There's no testing involved. What do you think that's a good solution?
No, not if there's the option of something like what we do. I fully understand, because women they're trying to go through, again, primary care, sometimes they're gynecologists. And if they're just they really kind of feel and they know that something is off hormonally, and they're just not getting the answers that they need. Nobody's really stepping up to the plate. I fully appreciate going online and ordering, but whoever, if there's a provider on the other end of that person is really just kind of checking off a box. Like, it's not individualized. They don't know this woman's individual chemistry, metabolism, hormonal makeup. There's probably no testing. I don't know if they're looking at medications and supplements that she's already on. Like, we spend an hour with somebody, and that's after having the blood work done, just going through, and again, it's a customized medicine. It's so individualized, and that's what every woman deserves. And yeah, I just wish more women knew that we're here, and there's places, there's places like this. So no, I don't think that a mail order thing is ideal. If a woman's lucky, taking whatever is given to her will make her feel good, but and feel better. But there's more than that.
Yeah. How often do these things need ongoing care and adjustment? Like, how often are you like, I'm sure you don't get it right the first time every time. I know a lot of this is based off of symptoms and the way they feel, right? Everyone feels different at different levels. It's very personalized. That's why we do what we do. But how often is it like, okay, a year goes by, all right, then we tweak it, and another year goes by, it's tweaked more? Is it like once you get it, you got it?
No, I like seeing after a woman starts on bioidentical HRT, we like to do labs 10 weeks later. If she's doing, whether that's blood work or a Dutch panel. And then I like to see her basically 2 weeks after that. So I see her, and then 12 weeks later, I see her again. Yes, I'm reviewing lab results, and I'm asking, how is your sleep? How is your mood? How is your libido? All the above. Have things changed physically? All of that. I think that timing works really well. It gives the medicine long enough to kind of do its job, and for us to really get a sense of if we need to tweak it in what way. So unless there's something kind of unusual, she needs that touch point a little more frequently. It's on kind of a quarterly or every 3 month basis.
Okay, very interesting. How often do you see peptides play a like, or as far as peptides or any other tools, play a pretty, big role in moving the needle with women's hormonal health?
Yeah. So again, I'm not sure if viewers know what peptides are. I'll give my little quick explanation. Peptides are basically short proteins. So a peptide is a sequence of amino acids, and depending on the sequence, we can target different parts of the body, different tissues. So I would say in terms of a woman, again, in those perimenopausal, menopausal years, kind of dealing with hormonal fluctuations, there are some specific, we have a lot of peptides, safe peptides to choose from. If a woman is, here's an example, dealing with kind of joint pain, we're probably going to want to make sure the thyroid is in balance. We're going to want to make sure that her estrogen levels are adequate, and that's, make sure that once those are balanced, has the joint pain improved? Yes, there's other things like weight and other things like that. But if we then can want to tweak it further, she's like, I'm better, but I'm not as good as I want to be. We have peptides that target connective tissue. They target the joints, and they're anti-inflammatory, and it's completely safe to take along with bioidentical HRT. Here's another example. A woman has been dealing with poor sleep and anxiety. We're working on figuring out the right bioidentical HRT combination for her. We're working on the progesterone, et cetera. Same thing, better, could be even better. We are adjusting the doses. There's a peptide that has a neurotransmitter modulating effect, right? So it basically helps put somebody, a woman, into that relaxation mode, into that what we call parasympathetic mode that can help lower anxiety, help with sleep. Again, completely safe. It's not an SSRI. There's no dependency. There's no weight gain. Completely safe to do along with really any other medications, including hormone replacement.
Okay, gotcha. What are some of like the symptoms of something like menopause that, because obviously there's the classic ones, right? Like the weight gain, anxiety, lower energy. Are there any others that are less common or less known?
Well, I would say in some ways maybe like the joint pain one.
Really?
I think
how is menopause linked to joint pain?
I think it's the low estrogen. I think it's the low estrogen, and and maybe a little bit of the low testosterone as well. I think that we know that estrogen kind of has like a lubricating effect, and so just like we see dry skin, dry hair, dry nails, like vaginal dryness with a drop in estrogen, that's going to affect the joints too. And so I think sometimes that is overlooked. That's, it's that, I don't think that's like the most common symptom that's people would, when they're listing out menopausal symptoms.
Gotcha. Okay, cool. All right. So that is it for the menopause, female sex hormones, and bioidentical hormone replacement therapy. Now we're going to transition into the second talk, which is going to be about anxiety, depression, and functional medicine, talking about that mind-body connection. So if you're just joining us, my name is Cole Siefer. I'm one of the co-founders of MedMatrix, director of marketing too, joined with Dr. Rose. Nothing on here is medical advice. We're just simply for educational purposes only. So yeah, Dr. Rose, why don't you start us off? Like, I guess we'll start with a hot question. Like, how often is something like a SSRI actually, in your opinion, medically necessary versus there's a better root cause reason for, the way someone might be feeling psychologically?
Yeah, I mean, we've seen, I would say, an uptick in SSRI prescriptions over the last 20 years, probably 10 to 20 years. It's pretty common for me to see people come in, new patients come in, and they have been on an SSRI for 20 years and kind of they've moved from primary care doctor to primary care doctor, and it's just kind of, they just keep filling it. There are definitely situations when they are absolutely like the best tool, right? Again, depending on the person, there's like debilitating depression, maybe debilitating anxiety. The person, like, really isn't functioning, is having suicidal ideation. Yeah, like if that medication is managing that, absolutely. That's, when that's not the case, I think it's kind of a Band-Aid solution that sometimes works, not always so great. It has some side effects. It really takes effort. I think it takes some effort. It takes effort in terms of the part of the patient and on the provider to dig deeper to root cause, right? So is it a hormonal imbalance? Is it a nutrient deficiency? Is it a actual situation where the person actually needs to get out of a pretty bad marriage? That's not easy, right? Like, that's not just take a pill and you're fine. That's like, is some kind of therapy or counseling really, does that, the right kind of counseling, the right person for that specific patient, like, is that going to be beneficial? Again, it's just more effort, more time, and sometimes just more education than just taking a pill. So does that answer your question?
Yeah, it does. So, well, you mentioned the long-term side effects. Like, what are the worst of the long-term side effects with
yeah, I mean, we see weight gain, we see low libido, we see kind of a numbing effect. I don't know if people would call that a side effect. I think of it as a negative side effect, where they're just like that. You're just not, the person is just kind of not in touch with what they're feeling. They're not feeling much of anything. And to go through life like that for years or decades, I think is unfortunate. And, I don't have any studies right at the ready, but, there has been some evidence of kind of this, some of them actually like worsening depression. And I just think that there's other work to be done. There's other tools out there to help with mental health. And it's important that people dealing with anxiety and or depression or other mental health concerns know about those other tools.
Gotcha. Well, so let's talk solutions. What are the top 3 root causes of depression and anxiety that you see?
That's a big question.
Okay.
I mean, we can talk about childhood trauma. That's a whole conversation, right? We can talk about
so life circumstances.
Life. We can talk about like, I would put gut health / nutrient deficiency as one. And I don't know, this is a big question. I was going to say hormonal imbalance. Depends on the age, right? Depends on the age and the sex of the person.
Real quick, what do you mean by that? Are like women more prone to, or men more prone to, based on?
I think statistically we see that women are more prone to depression. I also think that sometimes women, this is a bold statement, but maybe are a little bit more in touch with their feelings, and kind of recognize what depression might feel like. But I also think that there's been a shift generation-wise. I think there's just, mental health used to have much more of a stigma, and I even see it among my patients. I have patients who are in their 70s and are a little bit more hesitant to talk about anxiety or depression. It's just, there's kind of been this, it's a little bit of a taboo, maybe especially among older men. And then I have men and women coming in who are in their 20s, and they're like, yeah, I have a diagnosis of anxiety, I have a diagnosis of OCD, and that's just how it is. And and it's I just think that's great. I think that just culturally that shift allows us to have a better conversation.
Mm-hmm. Yeah, definitely. And then when a patient comes to you with, whether they're diagnosed with something like OCD, ADHD, depression, anxiety, or they're, talking about it and say, hey, I have anxiety, but they might not be, diagnosed. What is your framework for like uncovering the root cause as far as like what functional medicine can do?
Yeah. So part of it is, I think, kind of figuring out that life piece of it. Like, are there significant layers of trauma that a referral to a therapist in conjunction with what we're going to offer, that really makes sense? Is there are there nutrient deficiencies? And so some of that's going to show up on our initial panel. And then if I want to do kind of a much more advanced test to find out about nutrient deficiencies, nutrient imbalances, I can easily order that. There's a fairly, pretty significant conversation around gut health and diet. So what is this person eating? Caffeine intake, sugar intake, alcohol, and then including like nicotine and cannabis use, all of those, so stimulants, depressants, and then gut health in regards to mental health. I mean, that's a whole nother conversation, that gut-mind connection. But, how well is this person actually absorbing nutrients? Maybe they're eating this amazing diet that, what they're eating is great on paper, but their gut health is so messed up that it's like, it's not really it's not doing enough. And so I'm looking at that. And then, yes, looking at, depending on the age, depending on the sex of the patient, what's happening hormonally. Is it a perimenopausal person who really didn't have anxiety or depression until she hit 42, and then nothing else changed in her life, nothing else changed in how she's eating, but all of a sudden she's dealing with really significant depression and brain fog, or anxiety and brain fog? Then we definitely have to think about the hormonal piece. Yeah.
Gotcha. Let's dive into the gut one a little bit, because that's a term that's thrown around a lot, is the gut-brain connection. Gut health affects everything. How does your gut actually affect things like depression, anxiety, OCD, ADHD, et cetera?
Yeah, so we have neurotransmitter receptors everywhere, but like the greatest concentration of those receptors is actually in the gut.
Not the brain, the gut.
Correct. And
we have more neurotransmitters in our gut than we do our brain.
Receptors. So
okay.
Receptors. Yeah. So it's called the enteric brain, ENTERIC. It's like that's like the part of the nervous system that's in the gut. And so we have these receptors for serotonin and dopamine and norepinephrine and all of that in the gut. And, if the gut is messed up, the microbiome is messed up, again, we can get into the weeds here, then your body's not going to respond optimally to those neurotransmitters. There's also, a lot of evidence or research coming out now around the importance of the microbiome. So those beneficial microbes and, an imbalance in that ecosystem, like literally being a huge piece of anxiety and or depression, and other kind of, the autism spectrum, maybe OCD, the whole gamut. So we're just kind of at the tip of the iceberg with that research, but I think there's something to it.
Gotcha. All right. So what are things you do in your clinical practice at MedMatrix to help patients who have, psychological things like anxiety, depression that are linked to the gut? How do you help them fix that and get better? feel their best again?
So there is a comprehensive stool test that I run quite frequently that gives me a good picture of the microbiome. It shows me just kind of how well somebody's absorbing their nutrients, what the level of inflammation is at the gut level. It rules out various infections, parasitic, bacterial, viral, all that. So it gives me a good baseline of kind of the gut health. And I'm doing that. I'm talking to them about what they're eating, how much they're eating, what if they have any digestive symptoms, if they have any mental or emotional symptoms, kind of link that together, right? And then I usually like to treat in parallel. And what I mean by that is I like to both start to support the gut, and we can also start to kind of balance those or modulate those neurotransmitters, like do mood, help with mood regulation, help with that mental health, essentially. I think we can do those at the same time. We don't have to just start with the gut, wait a year, and then decide that we can start it, because there's such an interplay. They're so interrelated that supporting both systems, nervous system, gut, digestive system at the same time can be very effective. Are you looking for specific tools that I use?
Yes, but I love specifics. So why don't you explain to me the specific things that you use to improve the gut-brain connection and in turn anxiety, depression, things like that?
Yeah. So there are some peptides that we use. One is BPC 157, and that one actually mimics our own, a part of our own stomach acid. So I talked about peptides maybe in the last podcast, but basically a sequence of amino acids. And so the sequence of amino acids that makes up BPC 157 kind of mimics, again, our own stomach acid. It has a very strong anti-inflammatory effect. So yes, it does reduce inflammation in the joints, but it also reduces inflammation in the gut. And that reducing that inflammation is going to kind of help you absorb your nutrients better. If you can absorb your nutrients better, like your vitamin D, like your B12, like your magnesium, for example, like your iron, you are going to have a better kind of neurotransmitter balance. You're going to have better brain chemistry, I guess, is one way to put it, and kind of make those receptors just kind of more available, more sensitive to the circulating neurotransmitters that need to be balanced for optimal mental health. The other piece to this with gut health is kind of the detoxification pathways. And so making sure that, somebody is having regular bowel movements, is not constipated, because then you're just if you're not really fully eliminating, then your hormonal balances are going to be, out of whack. And even the neurotransmitters are going to, things aren't really circulating the way they should. And we need that to be optimal.
It's amazing how everything's connected.
Yeah.
Right. Your pooping to your sex hormones, your neurotransmitters.
Who would ever think that pooping regularly would improve your mood? But I think we all know that it kind of does. Yeah.
All right. So, man, I mean, that would be really scary if someone was taking a anxiety or depression medication when it was actually a gut issue or a sex hormone imbalance issue. Obviously, there's other contributing factors, but how often are patients coming into your practice and they're on? I guess let's start with this. How many patients? What percent of patients do you see are coming into you already on something like an SSRI?
25 or 30%.
Really, that many? I didn't know
that might be a little high.
Okay.
It's something, yeah. That
Wow.
might be a
All
little
right.
high. It might be a little high, but it's not let me put it this way. It's not uncommon.
Sure. Yeah. All right. How often are patients getting off of these meds after help with functional
Yeah,
medicine?
I mean that one takes a while. That's not a after 1 month they're off of it. I mean that
Mm.
those you do need to kind of wean off of. And obviously, if they're working with a psychiatrist, we're kind of doing it with their blessing, with their support. And but yes, it definitely happens, and it can happen in a healthy way. One thing that I do like to tell patients is, if if it's depression that we're dealing with, if there's a SAD or a seasonal affective disorder component, this time of year is not usually the best time to play with going with stopping your antidepressant.
Sure.
But that said, we make sure that their vitamin D levels are optimal. We give them all these other supports. If they're really committed to going off of it, like, we have the tools, right? We've got some other peptides. We've got some great kind of nutraceutical supplements that can support, for example, serotonin, melatonin, dopamine, or all of those, as if they are choosing to cut back or go off of their SSRI.
Okay. Yeah. Do you have any good patient stories of someone who came in and like kind of some of their, one of their main goals was like maybe getting off a depression med, or they were struggling with depression and mood, and with the help of functional medicine and what you did, you essentially turned things around? Do you have any, case studies that come to mind?
Yeah, I mean, I think the one case I'll just bring up, because it's pretty common, is a woman who I think she's early 50s, and she's one of those ones that had been on Wellbutrin for 20 years. Hadn't really
Wow.
She was just on it, right? Again, like, it hadn't really questioned it, and maybe wouldn't say that she was still depressed, but again, that kind of little bit of, a little flat, a little disinterested in life, brain fog, weight gain, what I will call kind of classic or common perimenopausal symptoms. And we put her on some low dose bioidentical HRT. And I worked with her on both kind of sugar and caffeine dependence. And when I didn't ask her to completely quit. It was more about amount. We looked at micronutrient levels, kind of adjusted those a little bit. And in my recollection, I didn't know that it wasn't necessarily like the spelled out plan that she was going to go off of her medication. It kind of happened organically. And so when I saw her 3 months later, she was feeling better. She was like, overall better energy, less brain fog, just like better mood. And then when I saw her 3 months after that, so 6 months after initiating kind of some of these lifestyle changes, the HRT, she had basically gone off of it and was feeling totally fine, maybe better.
Awesome.
And, yeah. So it's kind of simple, not super complicated, but again, she was the one that kind of initiated it. It kind of felt organic on her end.
Great. Oh, that's really exciting. Yeah, thanks for sharing. How are sugars and nutrients related to things like anxiety, depression, ADHD?
Yeah, I mean, like with ADHD, it's like kind of it's a little counterintuitive. It's usually kind of like low dopamine, low norepinephrine, and taking stimulants kind of relaxes the person. And I think we see that's what sugar is, right? That's what caffeine is. Those are stimulants. And so I think there's like kind of this If you have that kind of brain chemistry, this is just ADHD, it's a way to kind of self-medicate. And so I think it depends, again, on the neurotransmitter baseline, right? And we do have tests that we can easily test to see if where somebody's dopamine is, their all of the there's so many neurotransmitters, and we can easily do a panel on that. We're trying to like really diagnose it, but sugar is addictive, caffeine can be addictive, and they can be used to it's like false energy. You know what I mean? Yep. It's kind of it props you up. People, it's easier than, again, getting to the root. Why am I not sleeping well? Why am I tired? It's just kind of like an easy, very available way to self-medicate. And it's not really sustainable if you want long-term health, if you want kind of that longevity, if you want like to live well. Does that, I don't know if that answers anything.
Sure, that makes sense. Let's see here. Let me go over my notes.
And I just want to clarify, I'm not saying that caffeine is bad. I'm not saying that sugar is bad. It's about like the amount and the frequency, and in relation to like what else you're eating.
Gotcha. Okay. Yeah. How often, I'm going to ask a probably controversial question. How often is like these, the diagnosis of like a psychological, disease, like, I don't know if that's the right vernacular, but something like depression, anxiety, OCD, ADHD, a cover up for, something that's deeper seated versus legit?
I don't know if it's like necessarily a cover up. Like with anxiety, for example, there's such a range, right? You can suffer from panic attacks, or you can have generalized anxiety disorder. I think that you can have those things, but maybe what you're getting at, and I would agree with this, is that there's more underneath that, right? So is there an imbalance in the autonomic nervous system? Is the autonomic nervous system in sympathetic overdrive, right? This person's operating in fight or flight response because of a metabolic imbalance, because of like a neurotransmitter imbalance that isn't really anxiety, but it's showing up as anxiety. It's showing up as like a racing heart, palpitation. So if you've heard of POTS, postural orthostatic tachycardia syndrome, that's like a type of dysautonomia, and anxiety is like often like a big part of that. And if that's missed, if that diagnosis is missed, that person is just going to be labeled as being anxious. So I think it's often maybe more complicated. There's a hormonal imbalance, a metabolic imbalance, a neurotransmitter imbalance that is not being addressed / recognized. And in a primary care visit, which is 5 minutes, it's not the only option, but what happens is that antidepressant, that anti-anxiety medication is handed out. Maybe a referral for counseling, but it's just not that. That's all that's done, and it's not looking for underlying issues, testing, et cetera, all the stuff that we do, and kind of like really digging deep to find out where the imbalance is, what's going on, maybe in addition to the anxiety or depression, or what's like, what really is at the root for this person, because we're all different, and maybe it is trauma for one person, and maybe it's perimenopause for somebody else.
Yeah. Thank you for explaining that and articulating my question, because that's what I was getting at as far as like, from my understanding of this conversation, anxiety, it's not just anxiety. It could be an issue in the gut, it could be neurotransmitters, it could be sex hormone could be a sugar issue. So thank you for explaining. Cool. So that's it. We're at an hour for both of those talks. Dr. Rose, thank you so much for sharing. That was awesome. I learned so much. If you are not a patient and interested in becoming a patient of MedMatrix, just go to the website and you can submit a new patient application. And you can talk to a patient coordinator, and we would love to see if we can help you out. Dr. Rose, do you have anything you want to take us home with?
No, this was great. I just feel like the more that this information can be disseminated, like the better, the more empowered I hope people feel and know that they don't have to be limited by kind of the standard mainstream conventional medical tools, that there's just so much more out there. And yeah, the more the merrier.
Yeah. No, it's scary. I know you probably want to get home. It's later on a Friday night, but I want to share one little story because I experienced this firsthand, where I had a brain injury and I went to my primary, and they pretty much just said I had ADHD and to take Adderall, and that was it. And when I ended up going the functional route, it turned out I had some inflammation in my body and my brain from this brain injury, and I needed to do some things to work on that. But I had a underlying autoimmune called Hashimoto's, and my testosterone was really low because my pituitary gland was hurt from this brain injury. And when I fixed those things, my energy came back, my motivation came back. So yeah, I mean, it's just scary to think like patients out there who, might be taking something, right, an antidepressant, whatever it is, and there is a deeper reason to why this is going on, right? And obviously, there's most likely a psychological component, but digging deeper and making sure it's not there. If there is something in the gut, your body is at least working with you and not against you, right?
Absolutely.
Yeah, cool, awesome. All right, Dr. Rose, thank you so much. Have a wonderful evening. Thank you, everyone, for listening. Bye. Take care.